Good morning, Chicago. Today is April 4th, 2023. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. And as always, this is your chance to get your public health, including your COVID questions, answered live. Happy to be joined by a special guest today. This is your first time, I think, on Facebook Live. This is Dr. Irina Tabidze. She leads a lot of our work related to sexually transmitted infections at the health department, especially a lot of the data work. And you all have continued to have questions about sexually transmitted infections, or what we call STIs. A lot of interest in this during the height of the monkeypox or the mpox outbreak. But we decided, again, we're using this opportunity to highlight some parts of the department that people may not know as much about. So Irina, can you tell folks just a little bit about yourself and your background so they can start putting in questions?
Thank you so much, Dr. Arwady, for inviting me. My name is Irina Tabidze, as Dr. Arwady mentioned. I serve as the Director of Division of Public Health Services within our Endemic Infectious Disease Bureau. Divisions that I'm overseeing is responsible for surveillance, which is pretty much systematic collection of the data on all reportable conditions. And also within the division, we have a team of contact tracers that are doing public health intervention and following up on individuals who are diagnosed with STI, sexually transmitted infections, or with HIV. And we'll also have a wonderful team of epidemiologists who are doing data analysis and who are responsible for data dissemination in the form of the report, publications, and presentations. I am with the health department for over 20 years. I love the work I do. And again, things are changing in the world of sexually transmitted diseases and HIV, and I'm really thankful to Dr. Arwady for inviting me to talk today about the, and especially April, it's STD Awareness Month.
Exactly, that's part of the reason.
Much.
Yes, exactly. Perfect, perfect. So as always, just to remind you, if you have questions either for me or for Dr. Tabidze, Irina, you can put them directly into the box below. You can also use the hashtag AskDrArwady on either Facebook or Twitter. And one of the reasons we wanted to do this is that a lot of people started to understand, what does the Chicago Department of Public Health do during COVID? But a lot of that work, whether it's contact tracing, whether it's education, whether it's using data to really change the way we control disease in this city, grew out of all the work we've done for decades and decades in infectious diseases, and HIV and other sexually transmitted infections are a big part of that. So you can go ahead and start putting your questions in. As always, we will start with a look at some of our COVID data, and then we have a presentation of what's been going on in public health. Irina has some slides about sexually transmitted infections, and then in the second half or so, we'll turn to your questions. So let's start off with the data. As always, chi.gov/COVID- is your dashboard for all things COVID data. And if we pull it up here, you can see that Chicago's COVID risk level is still low. We have been there for a while, and we're happy to see it. And if you look at all the data across the various main metrics, you see everything is green, which is what we like to see. Laboratory confirmed cases, hospitalizations, deaths are all down. I do want to highlight that still there are 11 Chicago residents every single day being newly hospitalized with COVID-19, and we're averaging about one death every other day right now among Chicago residents from COVID-19. So this is not over, but it is in just a remarkably better place compared to where we were, of course, 3 years ago, but even 2 years ago or 1 year ago. The only number that is red here is our vaccinations administered. That's our daily average of COVID vaccines. But I do want to highlight, we're doing between 400 and 500 vaccinations for COVID every single day in Chicago residents, even now, and that remains critical. I'll also just show you down here, when we get a lot of questions in from you, we will often take the opportunity at the bottom of the dashboard here to link to some of our other dashboards or more specific work. And so there's a couple of things that have been linked more recently to the COVID dashboard. So you all are always interested in wastewater surveillance, and I thought I'd show you some of what we've done here. So under wastewater surveillance, just as a reminder, wastewater is another term for sewage, and the idea is that somebody who is infected with a disease, a virus or a non-viral illness, even if they don't have symptoms, they can shed that virus in their stool. And so in the case of COVID, we're able to look at wastewater data at a population level to understand what's happening with COVID in a way that doesn't depend on an individual to go and get tested. So of course, we look at case counts and hospital admissions and all of that, but this is some of the newer data. So I wanted to orient you that we have four main treatment plants in Chicago. Well, three, but we divide Stickney into two. And so you see how I clicked on Calumet here? On the left, it shows you what part of Chicago is covered by the Calumet treatment plant. So you can see the shaded area, that's the city of Chicago. All of these treatment plants also serve suburban Cook County. And you can see that this whole treatment plant has an estimated population of about 1.1 million people. So in those 1.1 million people, you know, if you go back over the last year or so, this is what the levels of COVID in the wastewater have looked like. And this line kind of shows you the average. And then every week up at the top, we're saying, are levels going up? Are they going down? Or are they about the same? And they're about the same. If you click across the top here, just to give you one more example, you can see what the geography looks like. Stickney North covers this area. Same thing. This one also is about the same. And then in addition to these treatment plants, the four divisions that cover the entire city, we also are doing this smaller work of what's called a sewer shed. So let's choose like Chicago Lawn Ashburn here. On the left, it'll show you. See, it's a much smaller area within Chicago. It's only covering about 78,000 people, but it lets us get a little bit more of a sense of, at a more hyper-geographic level, what might be going on. So we see here that in Chicago Lawn Ashburn, you know, levels are decreasing. So you can explore. There's much more data about how we do this and all kinds of things on here, but I just wanted to highlight that is available, and we are updating that data weekly. If we go back to the homepage, I'll also just highlight, we've done some linking to the other respiratory virus surveillance that we do. Surveillance is just a fancy word for data intelligence and data monitoring. And right now, it's a link to weekly reports that the team puts together. So if you click, for example, on this most recent report, you know, what's happening with COVID, what's happening with flu, what's happening with RSV and para-influenza. There's some graphs and some data. We are actually going to have some more dashboards in the way that people have gotten used to, probably within the next week or two here. But in the meantime, this is a sort of a static report that comes out every week. Our healthcare providers use this all the time, but as we've got a lot of folks in Chicago increasingly interested in data, we've also made a decision to link it there. So all of the other things remain available and updated across the COVID dashboard. Remember that this here, summary cases by zip, that continues to update every week. You can look by zip. There's a lot in here. So that's a little bit of what's happening, but the news continues to be good. I'm going to go ahead and pull up the slideshow here just to go through some updates of what's been happening in public health. So again, Irina Tabidze is the guest today. And first, it is National Public Health Week. You may or may not have known that, but April 3 to 9 across the whole country is the week that public health is celebrated. The theme nationally is centering and celebrating cultures in health. A goal nationally is to look at cultural connections and intersections. How does that affect our health? How does that affect our well-being? How does that affect the public health system that cares for everybody? And also a focus, again, of thinking about what we can do, not just as individuals, but as communities when we're influencing the future of public health. So I'm always encouraging people to follow CDPH's social media. We've got quite a lot going on there celebrating National Public Health Week. We're doing little videos of CDPH employees talking about, you know, why they work at the health department, what they like about it. And it's just a nice opportunity for us to thank really the amazing team at CDPH. I also wanted to share some sad news. Yolanda Travis, who is the woman on the right here in this picture, standing with Antonio King, one of our CDPH employees. She recently passed away, and she was actually the first McDonald's franchise owner to come to CDPH during our COVID vaccination efforts back in the summer of 2021, when vaccines were widely available, but we were seeing lagging vaccine uptake, especially on the South Side. And she owned 3 McDonald's and said, I want to help. And at my 3 locations, what can we do? Can you bring vaccine? I'm willing to give free lunches if you can make it happen. And really very successful efforts. And she was highlighted both in an ABC News report here and then actually was featured on Nightline nationally as just a good example. There was a quote from that where she said, a lot of people don't like to leave the community. So I said, how can I make this available to people within my community around my restaurants? And that is the kind of attitude that I just have loved about the response in Chicago. We saw people step up across every corner of this city to say, how can I help? How can I make sure that the good news and the life-saving vaccine, is available to folks? And so we would work with the team. We saw other McDonald's franchise office owners follow suit. We had multiple events, had more than 100 residents get their first vaccinations through this. And so just wanted to give our condolences to her family, but also really just honor her memory and her example. So again, a huge thank you to Yolanda Travis, and sad to hear of her passing. Thank her and her family for her example. A few other updates. In case you missed it, we had a press release that the CARE program has expanded downtown. Quick reminder, CARE is the Crisis Assistance Response and Engagement Team. That's the program where mental health professionals are embedded into 911 response. And so if you call 911, we've now got 5 different areas of the city. There's different models that are happening. But the idea is while the CARE team is on, instead of just getting a police officer, you can get a trained mental health professional with a paramedic. And we've just expanded into the Loop. And so the CARE team in this case is made up of a CDPH mental health crisis professional and a Chicago Fire Department paramedic. That's the team. They travel in the van that looks like this. And it's, you can go to our website, chi.gov/care to learn more. But we've got expansion plans for 2 more areas still coming this year, and the Loop is our latest. So that's really good news. Also, an exciting piece of news in the last week or so was that the FDA approved the first over-the-counter naloxone nasal spray. Naloxone, or the name brand is Narcan, is the spray that reverses an opioid overdose, saves lives. It's been hugely important in combating opioid overdose here in Chicago. This is the program that, the CDPH has worked with Chicago Public Libraries. We have Narcan available free of charge. We've also crossed the benchmark. We've distributed over 100,000 fentanyl test strips to the community since that program launched. So there's a link there if you want to find free Narcan. But the fact that it is now over the counter is really exciting as we continue to expand access to this life-saving medication. We've also been getting questions about are you following other diseases? Of course we're following other diseases. I wanted to just highlight an example. The team that works on infectious diseases at CDPH is always tracking very closely outbreaks around the world. We know that this is a global society. We know that O'Hare is an international hub. And so right now, for example, we are following 2 Marburg virus disease outbreaks in 2 African countries, Equatorial Guinea and Tanzania. Marburg, if you don't know, it's similar to Ebola. It's very serious. It's very contagious. It's not spread by air. It's not spread easily. It's spread when a person is in direct contact with the body fluids of someone who is sick or who has died from Marburg. And you'll see, March 21st, Tanzania actually declared the country's first ever outbreak of Marburg, and February 13th, Equatorial Guinea had. And so I just wanted to give you a sense. Our team here is following this closely, partly so if somebody is, has traveled or has concerns, we know what's happening in that other country and are able to guide appropriate diagnostic care here, should it be necessary. Not a high concern at this point at all for Chicago, much more concern for ground and water-based travel. There is aggressive outbreak responses underway in both countries, which is the most essential piece. This is where, for example, the U.S. really contributing to that on-the-ground containment measures are critical. There are no direct flights from either country to Chicago, and in fact, very few travelers to Illinois or Chicago from these countries. Nationally, just only about 143 people a day from either of these countries across the whole U.S. come in. So CDC CDC already does some messaging for all returning travelers. They have a text illness monitoring system just to make sure if somebody was in an area and they develop symptoms, they know what to do. They know to contact a health department. They know, what to say. And then in addition, travelers' contact information is shared with the local health department. So CDPH knows if there's been a traveler to one of these countries during the time period of interest, and we're able to do some matching in case somebody came into an emergency department, just to make sure that they were getting the safe care that's needed. So that just gives you a sense of some of the behind the scenes work happening internationally. On the COVID front, the news is good. This map is almost all green. Last week, less than 1% of U.S. counties reported a high COVID community level in orange there, and just 9% reported a medium level. You can see in Illinois on the right, we are at low, and there are some counties that are at medium, but none that are at high. Just to remind you how that's calculated, across the whole country, they're looking at lab-confirmed cases per population. We want that number to be under 200 per population. In 7 days. You can see we're at 50 something, which is great. We're also looking at COVID admissions per population over 7 days. Our goal there is less than 10. City of Chicago is under 3, which is the lowest we have been in weeks. And Cook County is also well under that 10 mark. And then the percent of staffed inpatient beds taken up with COVID patients, the goal is less than 10%. We're at less than 3%. So we really are doing very well from a COVID perspective, but there are still ongoing cases. Nothing changes at that individual level, but no signs of concern. Variants, we get a lot of questions about this still. Everything is still Omicron. That dark purple is the subvariant XBB.1.5, which we've been watching increase since January. And now more than 90% of the cases here in Chicago and across the Midwest are that subvariant. Good news. We've not seen a new thing emerge, a new significant subvariant or variant of concern. Meaning if you had your vaccine, your updated vaccine sometime last fall or winter, you are still up to date and as protected as you need to be across the whole U.S. Also, it's all that dark purple XBB.1.5. So lots of work behind the scenes continuing here. From a booster coverage standpoint, we're at almost 600,000 doses now that Chicagoans have gotten since authorization. We're above the national average for the population over 5, over 12, and over 18. But I've been saying this week after week, we are still behind the U.S. average for people over 65 getting that updated booster. And that is the group that it is most important for. That is who we are seeing getting admitted to the hospital by and large. That is who we are seeing still dying from COVID by and large. And so if you know anybody who's not up to date, but especially over 50 or over 65, it's critical. And I want those folks to make up our 400, 500, 600 vaccines we're doing every day. I already highlighted that the wastewater dashboard is live. And I showed you that. And I highlighted that the weekly respiratory virus report is now linked on the dashboard. Influenza activity is low. How do we know that? We've had one ICU admission in this last week across all of Chicago for influenza. Less than 1% of the specimens that we're testing were positive for influenza compared to 9% at the peak. RSV is low. As one example, the percentage of emergency department visits in young children is less than 1%. Some of the viruses that are, increasing a little right now are the common cold type viruses: parainfluenza, rhinovirus, enterovirus, adenovirus, HMPV. So there's plenty of viruses going around, but not the ones that are highly likely to land folks in the hospital. So that's good news. Just a very quick reminder on COVID: you need to take action just like you have all along if you test positive for COVID. Days 1 through 5 after testing positive, you should be staying home, regardless of vaccination status. If you're at higher risk for severe illness, you should be talking to your doctor or pharmacist about getting that early treatment. Day 6 or later, if you're feeling better, you can end isolation, leave your home, but days 6 through 10, you should really continue wearing that mask to help cut down on the risk of transmission. I also just remind people, belt and suspenders, vaccine and Paxlovid, Vax and Pax. If you're at higher risk for severe illness, over 50, underlying conditions, most important, be up to date with vaccine. But if you do test positive, even if you are not vaccinated, we absolutely want you to get these early treatments. These keep people out of the hospital. They keep people from dying. Paxlovid's the best known, and there's more information online. But you don't want to wait. You can't decide a week or two into having COVID, oh, I feel badly, I want to take Paxlovid now. You've got to take it in the first few days to keep the virus from copying. And just a final reminder that we continue to operate our Protect Chicago at Home. The city will bring anybody in Chicago free vaccine, COVID boosters, flu shots, Saturdays, Sundays, and Mondays, 8 a.m. to 6:30 p.m. by appointment. So you can give us a call or visit us. With the end of the public health emergency, that's another area we've been getting a lot of questions. I wanted to just say a little more about Medicaid re-enrollment. So across the whole country, during the federal public health emergency for COVID-19, families that were receiving Medicaid were automatically re-enrolled every year without needing to resubmit paperwork. You couldn't remove anybody from the Medicaid rolls during the emergency. But now that the emergency is ending, scheduled to end in May, families across the U.S. are again going to need to renew their Medicaid benefits starting this year. And so this just ended March 31st, and the state of Illinois will be mailing out renewal forms starting in May. So that date in May would only be for people whose coverage needs to be looked at and redetermined by June. So you might have a different redetermination date. The point is, you will get a notice in the mail about a month before the due date. So the most important thing you should do now, if your family currently receives Medicaid benefits, is to make sure your contact information is up to date so you get your renewal form. What we don't want is people, we know folks have moved, they don't know the address, they don't know they have to do this, and they can lose their insurance coverage. So there's more information here, but really right now, get ready to renew. You can go to abe.illinois.gov and click Manage My Case. And the point here is to see if you're still eligible. There's more information here. There's also a phone number. We know not everybody is online, so you can call for free 877-805-5312 Monday to Friday to make sure your address is right. And then you'll be completing your renewal. But if you don't respond, you could lose your health insurance, even if you're still eligible. Chicago Public Schools is also helping with this. So if you have any questions and you're a CPS family, you can call the Healthy CPS hotline, 773-553-KIDS or 5437, or visit cps.edu/Medicaid. As always, now in Chicago or Cook County, you can call 211 if you need help with health or social services and you don't know where to turn. And as always, CDPH will handle any questions about COVID 7 days a week. We've got live folks answering 312-746-4835. So to transition to our other topic, I wanted to just, we talk a lot about sexually transmitted diseases, but really we talk a lot about people who are sexually active and making sure that they are healthy. Monkeypox, of course, has been a big focus this last year. We had a big outbreak of Mpox last summer predominantly, and you can see that has largely tailed off, but it hasn't ended. We had another case this last week. We definitely are still encouraging providers to test, people at risk to get vaccinated, but we update this every week if you want to follow. This is what our vaccination numbers look like. And I just wanted to highlight in terms of how have we done on Mpox vaccine. CDC estimates that about half of the people living in Illinois who should get the Mpox vaccine have gotten at least that first dose. And that's that green box on the bottom there. Illinois is at about 50% for the first dose, about 29% for the second dose. That's actually pretty good compared to a lot of other states. You can see Indiana, only about 21% have gotten that first dose, and only about 9% is the estimate have gotten the second. But it is still, there are a lot of folks out there who are not fully protected. Our estimates in Chicago are a little higher than this, but overall there's still work to do. And I'm not going to go into this in detail, but this is some of the kind of important work that happens after an outbreak to understand where do we put vaccine, how likely is it we're going to see an Mpox outbreak. And so some modeling that was done showed that places with high vaccination coverage, like more than 75%, really the modeled risk of having another significant mpox outbreak there is pretty low, just 5 to 10% each year for the next 5 years. And those would be predicted to be pretty small, like less than 15% as many as the outbreak. But in places with low vaccination coverage, like less than 35%, we're in the middle here in Chicago and Illinois, but we would expect resurgent outbreaks, as large or even larger without more vaccination or more sexual behavior adaptations. And so it is important, and we've been really emphasizing, especially with people, clinicians who treat folks with sexually transmitted infections, to vaccinate people most likely to be exposed to mpox. That is anybody, who's been diagnosed with a sexually transmitted infection, or gay, bisexual, other same-gender loving men, or if they've had more than one sexual partner in the last 6 months. That's an example of a risk group that really should be vaccinated. And in the U.S., HIV or recent STIs are common among people with mpox. And so it's just a good example of, as I hand it over to Irina Tabidze, who works on our sexually transmitted infection work at the health department, a lot of you have come to public health because of these recent outbreaks. You've paid more attention, but very often we see connections between where outbreaks are and the work that we do all the time. So with that, I will hand it to you to talk through some more work related to sexually transmitted infections.
Thank you, Dr. Arwady. So just brief reminder, month of April, it's sexual STD awareness month, and I think part of today's conversation will be pretty much focused on sexually transmitted diseases. However, before we talk about the sexually transmitted diseases, I wanted to touch base and briefly talk about the syndemic approach. This is a term that actually we, Bureau of HIV STI was rebranded in October of 2021, and so we became Bureau of Syndemic Infectious Diseases. And main reason is that, some other conditions such as viral hepatitis, tuberculosis, also were under the same Bureau of HIV STI. So what term, I will briefly want to touch base about the term. Term actually was developed by medical anthropologist Dr. Meryl Singer. She's a faculty at University of Connecticut. And so pretty much syndemics is a combination of two terms, it's synergy and epidemic. A syndemic approach, it's it's a combination of two or more overlapping epidemic connected through behavior, biology, social condition. It resulted in enhanced health burden across the population. So when we look at all of the infections shown on this slide, it's HIV, syphilis, viral hepatitis, TB, or gonorrhea and chlamydia. All of them are interconnected. So there's a clustering of the case. So it was one of the main reasons why we are right now calling ourselves Syndemic Infectious Diseases Bureau. This is a slide to show current syndemics in Chicago. It's called Venn diagram, and it's using the circles to show the relationship between other conditions. For this particular case, we're sharing the data for a chronic condition such as HIV and a co-infection with the other conditions. Also, if you can look at the slide, so data for viral hepatitis C is from 2017, and remaining data is from 2020. I wanted to emphasize, so if we look at the co-infection rates, so percentages might look small. For example, that individuals diagnosed with HIV, 5% of individuals diagnosed with HIV were co-infected with chlamydia in 2020. If we look at the co-infection with gonorrhea, 11% of individuals diagnosed prevalent HIV cases were co-infected with gonorrhea infection. And if we look at the primary and secondary syphilis among individuals diagnosed with HIV, close to 33% of individuals were co-infected with HIV. Why it's important? Percentages is small, but if we will look at actual numbers are much higher. So when we talk about the chlamydia, close to 1,500 individuals were co-infected with HIV. When we talk about co-infections with gonorrhea infection, we're talking over 2,000 individuals. When we talk about the primary and secondary syphilis, it's really important to notice that, actually in the previously, co-infection rates were much higher in the 50%, and, in 2020, we were at 33%.
So can I just ask just a quick question here, just to make sure folks are sort of seeing this? So in this purple in the middle there, we had looks like about 20,000 people living with HIV, right? That were diagnosed in Chicago. And then the idea is that there's the overlap. So like up on the left there, primary and secondary syphilis, 33% of the people with primary and secondary syphilis also had HIV. Is that what that means?
HIV positive individuals who were diagnosed with primary and secondary syphilis in 2020.
Perfect. Okay, great. Yeah, I mean, and so you don't want to have separate programs where people are coming and, you know, you're only evaluating their HIV, you're not looking at their risk for these other things, treating them. Okay, gotcha.
Absolutely, absolutely. Thank you, Dr. Arwady. So we are seeing unprecedented rise in STD, not only locally, but nationally as well. In 2021, over 27,000 of chlamydia cases were reported in Chicago, over 19,000 of gonorrhea cases were reported in Chicago.
It's a lot.
It's a lot. It's close to 800 primary and secondary syphilis were reported in Chicago. Most of the cases, actually, its trends are following the national trends, and most of the cases are within the same populations that Dr. Arwady was just describing about the mpox. It's across the same population among most of the cases among males and gay, bisexual men, and as commonly called as MSM. But today's presentation will be mostly focused about syphilis because I think it's the most serious sexually transmitted diseases, and I will very briefly provide update on causative organism for syphilis and how disease is transmitted. Syphilis is caused by bacteria called Treponema pallidum, which is typically spread by sexual contact. And signs and symptoms of syphilis can be difficult to detect. The disease divided by early stages and late stage of disease. And the most importantly, it's important to remember that most infectious stages of disease are symptomatic. Individuals presented to the clinic will have most of the time have either primary lesion called chancre, or the individuals may present with a generalized body rash, which also, and diseases progress even without treatment. Signs and symptoms can disappear and will fade away. But it's really important to remember that this individual without treatment can progress to the later stages of disease, which is defined as a late phase of disease.
Which is why we want people who have sores, they're not sure what they are, rashes, you got to go see your doctor just to make sure you're getting diagnosed appropriately.
Yeah, and unfortunately, syphilis is most of the time is not included as part of differential diagnosis.
Right.
Providers are diagnosed as contact dermatitis.
They're not thinking of it because it's not that common, right?
Exactly, exactly. This is a slide which shows the epidemiology of syphilis here in Chicago since 1980s, and it's the reason I wanted to share this data because it really shows what is currently happening. Back in 80s and 90s, in the 90s especially, the numbers of, syphilis was mostly equally divided among heterosexual population, mostly among males and females, and mostly was attributed to crack cocaine outbreak. However, trends changed in 2000 when the initial cases were diagnosed among men who have sex with men. Since then, number of the cases in the late 1999, syphilis elimination efforts started. However, as soon as this plan was announced, cases among MSM mushroomed, and we start seeing increases cases every year since that. In 2021, we reported close to 800 primary and secondary syphilis cases, and higher proportion of the cases are among males. What is really concerning when we talk about syphilis is that, we start seeing most cases now not only among men who have sex with men, but among heterosexual population, primarily among females diagnosed with the primary and secondary syphilis. Another recent changes are that syphilis usually was diagnosed among older adults, individuals in the 30s and 30s or 40s. However, trends changed, and now we're seeing more younger individuals diagnosed with this syphilis among heterosexual population as well. So just to summarize, this slide shows that most of the cases, this is the data from 2020, most of the cases still remain among males, 60% of the cases among males, and among male cases, close to 90% cases among men who have sex with men. If we look at the age group, as I just mentioned, then most of the cases are 60% of the cases individuals 30 and above. However, it's very concerning that we start seeing more use in younger adults and adolescents who are diagnosed with the primary and secondary syphilis. Trends with regards to distribution by race ethnicity did not change much over the recent years, and most of the cases predominantly among non-Hispanic African Americans. Some community areas are more impacted than others. So this is a map of City of Chicago by community areas, and map shows the distribution of case by rates as well as the number of reported primary and secondary syphilis cases. Highest rates were in the 3 community areas reported in 2020. It's West Garfield, Uptown, Edgewater, which is consistent with the previous years. However, if we look at by distribution of the cases by community areas by number of reported cases, higher number of cases are Uptown and Austin and Edgewater. I wanted to focus today's presentation specifically and talk about transmission of syphilis, transplacental transmission of syphilis from infected mom to her unborn newborn baby. Unfortunately, most of the cases, syphilis can be transmitted during the pregnancy at any time during the gestation, and any stage of syphilis can be transmitted. What is really important to know is that if female is diagnosed with primary and secondary stage of disease, the transmission rates are much higher than if female is diagnosed with the late stage of disease.
So if they've just recently been infected, it's potentially more dangerous for the baby.
Absolutely. And most of the historically close to 35% of the newborn babies who are born from the infected mom, most of the times there can be a stillborn cases, or neonatal babies can die right after the birth. So it's really, really important to prevent it, and just to do everything in our power to prevent transmission of syphilis from pregnant female to her unborn child. This is a slide to show nationally what is happening nationally. As nationally, number of congenital syphilis cases are increases, which is showing in the blue bars. And the red line shows the distribution of primary and secondary syphilis cases among women of reproductive age within the age group 15 to 44.
And this should really be 0, right?
Absolutely, it should be 0. So between 2016 and 2020, as you can notice, total number of congenital syphilis increased by 235%. This is the national data. What is really also important to note is that in some community areas, some parts of the country did not have even single cases, and that's not the case. As of 2020, almost each and every 49 jurisdictions nationally have reported the congenital syphilis case. So this is a slide to show you what is happening here in Chicago. Back in 80s and 90s, numbers of cases among females were in the 300s and 400s. However, cases were, among females, and I'm referring, when I'm talking about cases, mostly I'm talking about infectious stages of disease, were declining every year since, beginning of 90s and 2000. What is really important to mention is that Chicago, in 2019, just prior to pandemic, we reported only 9 cases, and this was the lowest ever Chicago reported number of congenital syphilis cases. And despite the fact that nationally cases were increasing, Chicago
that's that black line there.
Exactly. Chicago, it was only one jurisdiction, I would say, nationally, who reported the lowest numbers. So we were on our way to eliminate congenital syphilis. But as of we all know what happened, pandemic happened, and unfortunately, since pandemic, every year we see more and more cases. Based on the very provisional numbers in 2022, we will have more cases reported. As of last week, we have already 35 congenital syphilis cases reported to Chicago Department of Public Health. Just to summarize, as I mentioned, that it's very sad because we got so close to elimination of congenital syphilis in the city.
And congenital syphilis, that means syphilis in the baby.
Congenital, it means syphilis in babies. But since we did once, there's a hope that we will be able to do it again. So in 2019, we reported 9 cases. In 2020, as you can notice, we reported 19 cases among babies diagnosed with syphilis. In 2021, it was 25 cases, and in 2022, again, this is very provisional number. We have 35 cases already reported to Chicago Department of Public Health. So overall, between 2016 and 2020, it's an increase in total of 191% increase in the number number of reported cases among babies. This is a quick snapshot which shows that overall what happened with the congenital syphilis cases between 2016 and 2021. And just to summarize, overall it was 71 live births. So during this time period, we have 5 stillborn babies born during this time period. Most of the cases were among young females. Median age was between 26 and 25, and it pretty much remains the same over the years. And most of the cases were among non-Hispanic African American females. What I wanted to emphasize that initially when we start seeing the congenital syphilis cases and we look at the different community areas, so most of the cases were on the south side of the Chicago. However, we see the numbers of cases are increasing also on the west side of the city, and also based on the 2022 data, we start seeing some cases on the north side as well. So there is no any single community areas that we can say that, for a targeted intervention especially, it's really important to know which community area we need to do targeted intervention. However, cases are, the cases are across the entire city of Chicago, so we need to be more strategic which community areas and what type of interventions we need to develop. So again, this is a slide just to show that overall, when we look what are the trends of distribution of the case by race ethnicity between 2010 and 2022, as you can notice, shown in a red line, most of the cases among African American females, and trends unfortunately did not change over the years. In opposite, we see upswing of the cases after the COVID pandemic in the same population. When we look at the data, and the data which I shared with you, data tells us about the number of diseases. However, we're always trying to identify what are the main reasons why we're seeing the newborn babies born with congenital syphilis. And one of the things, this is a slide, it's colorful slide, and so I wanted to mention that, we are using the CDC's case definitions, and we're using the CDC's case classification when we look at the missed prevention opportunities for prevention of transmission of congenital syphilis. And one of the most common, and it didn't change, it's a lack of no prenatal care. So over 48% of females, if they don't receive prenatal care. Mm-hmm. And again, if you don't receive prenatal care, it means you are not getting tested for syphilis and you are not getting adequate treatment for syphilis.
Because if you test, you can treat and prevent the baby.
Absolutely. Mm-hmm. Another common theme is that we notice that, although some females are getting tested for treatment for syphilis, sometimes they're treated inadequately for syphilis. Mm-hmm. So initially, when I was providing quick overview of the syphilis as a disease, I briefly mentioned that there's the early stages of disease and there's the late stage of disease. And treatments are different. So it's really important for treating providers to know and treat the individuals according to the stage of the disease. So second most important factor was that, females received the prenatal care. However, they were inadequately treated. One of the facts was it was a syphilis, and again, it's very complicated disease. It's called great imitator for a reason. But, I will give a simple example. So, for example, if a female is diagnosed with late syphilis, it's really important to receive 3 shots, 3 injections of the penicillin. And it's not only what type of medicine, but how often you are giving this medicine. It's really important to give the medicine once every 7 days. So if individual was treated and the second follow-up visit was in the 10 days, it's already missed opportunity to treat the female adequately. So this is just simple example. For example, we have a 25-year-old female who reported to the hospital. She's unemployed. She has no reported drug use, no previous pregnancy. She had her first prenatal visit and she was tested negative in November 15. She came back on February 7 and she has a third prenatal visit. She was in a third prenatal the trimester. However, no syphilis test was ordered by prenatal provider. In April 1st, she reported to the hospital. She presented to the hospital with concerns for COVID, and she delivered she had a stillborn baby delivered in 20 weeks of gestation, and at the time of the delivery, it was noticed that female has a generalized body rash, and on April 15th, patient was treated for secondary stage of disease. So what this case is showing that if female would have been tested during the third trimester, this is exactly the time when she developed this secondary syphilis. So this case was preventable if she would have been tested and treated at the time of the visit when she came in February 7th. So what we as a health department are doing, we are basically, prior to COVID pandemic in 2019, we formed the Chicago's Syphilis Elimination Task Force. And Syphilis Task Force, it's CDPH, represented by CDPH, but also represented by clinical and community providers, who despite the COVID, we were able to meet throughout the entire year of 2020, 2021. All of the calls were virtual, but we knew that it's really important. And we were predicting that number of the cases and trends for syphilis will change right after the pandemic. So we wanted to develop the recommendations, specific recommendations, how to approach the changing epidemiology of syphilis right after the COVID pandemic, which we developed. It very soon will be published. Another thing that we are doing, we are working, despite again COVID, we were working with the different training centers, and we started grand round presentations. And we were working closely with the St. Louis HIV/STI Prevention Training Center. We started grand round presentations through the major hospitals who were reporting the highest number of congenital syphilis cases. But of course, data, and data. We enhance surveillance. We're asking all healthcare providers to report the data in a timely basis to the Chicago Department of Public Health. So this way we can analyze the data and provide the feedback or any support to healthcare providers if needed. Contact tracing, I initially mentioned that we are doing contact tracing. We call team members who are doing contact tracing, we call them disease intervention specialists. This is the team members who are very skilled, and they're following up on all of the new diagnoses of syphilis among females especially. So plan is, as soon as we receive the information on the pregnant females, our disease intervention specialists are reaching out to find out what are the risk factors, and most importantly, how to prevent further transmission of the infection, and if needed, to provide the treatment, adequate treatment, not only to female, but to her partners as well. We also are conducting public awareness campaigns on an annual basis, and we're making sure that we're using the culturally competent and linguistically appropriate messages. What do healthcare providers? We do need to work together. There is definitely help is needed from healthcare providers. I briefly shared with you one of the case studies, but if we look at the case studies, it's most importantly one of the risk factors that females are not getting retested during the pregnancy. According to the state of Illinois Prenatal Syphilis Act, all females should be tested not only during the first trimester, but during the third trimester, especially 20 weeks of gestation. It's also important for providers to know what is happening in their community, because some of the females, if they live in the community areas with a high prevalence of syphilis, it's really critical to test them not only at the time of the third trimester, but to repeat the testing at the time of the delivery. So this is one of the most important messages. Again, if there's a female who was, who delivered a stillborn baby, it's also important for providers to test the female for syphilis, because as I mentioned, that historically 40% of the cases are among females who are infected with syphilis. They're delivered during stillborn babies. So none of the females should leave the hospital without syphilis testing. Treatment. This is another thing that we need to make sure that gold standard for treatment for the syphilis, it's a simple injection of penicillin. Few years ago, there was a shortages of the penicillin. So what we are asking providers, if you have any support is needed with respect to the penicillin or long-acting penicillin, which might not be available on site for prenatal care providers. So please reach out to the health department. We will be happy to support, or please refer females females to our CDPH STI specialty clinics who will be able to provide the adequate treatment to females diagnosed with syphilis. Please don't delay. If a female has a diagnosis of syphilis, it's ideal to treat her as soon as possible. And also, please note that female can get reinfected if her partner is not getting treatment. So treatment should be provided not only to females, but to her untreated partners. I would also mention that, as I briefly mentioned, that our disease intervention specialists can provide support, and they are following up with the females diagnosed with syphilis. And if any support is needed, we're here to support healthcare providers any way we can. And I would just finish that routine blood test for syphilis pregnancy, pregnant mother and her baby. Please screen, please diagnose, and include the syphilis diagnosis as a differential diagnosis. If you see rash, a genital lesion, please order the syphilis test. Thank you, Dr. Arvadi.
All right, thank you. So that was a lot and very good. While we switch over to folks' questions, can you just underscore, why do you think we've seen this resurgence of congenital syphilis and syphilis in general over these last few years?
I think one of the major, so we're analyzing data, we're looking at the different risk factors among females, if there's any changes in the risk factors. But one of the things that I wanted to mention is that we did not see previously during the COVID pandemic, some of the healthcare providers instituted the telehealth. So, and during the telehealth, you usually don't order the test, you are doing the follow-up just to find out how female is doing.
Yeah.
And so quite a few females, they miss testing during this, and then I'm referring especially what happened between 2000 and 2022. So some prefer to have just a telehealth appointments and never got tested for syphilis. As a result, they were not treated. Another thing that, a lot of our disease intervention specialists were, all of them were deployed to do case investigation and contact tracing for COVID. So resources were limited on the health department side. But as I mentioned, that nevertheless, we never stopped the conversation of syphilis, and that was one of the reasons we were working closely with the healthcare providers citywide to make sure there is awareness that we knew that, and we don't have all tools in our toolbox to do the work. Specifically, when I'm saying this, I'm talking about rapid syphilis testing. There's the rapid syphilis HIV testing, but there is no rapid AS syphilis testing. So even if you want to do some field work and outreach, there's actually very recently, February, the new test was released, which is a combined syphilis and HIV test. So there is a hope that we will be able to do more outreach and to do a field work. So I think there's a complex of reasons what happened during the pandemic. Another thing, as I mentioned briefly, different risk factors. Some females didn't have a housing, unstable housing. Some females were exchanging sex for drugs or money. There's the risk factors as we should be also taking into the account. Incarceration, increased incarceration. But even if female does not have any risk factor, her partner might have one of those risk factors and can transmit this infection to female. I think it's a complex of the factors which led to increases. But I know that, as I briefly mentioned, that I really know that we did it once back in 2019, and I know that if we work closely with our healthcare provider, and most importantly with the communities, City of Chicago, we will be able to address this growing concern with congenital syphilis and syphilis in general.
All right, great. So a couple of just really practical questions that folks here. Somebody named Jess is asking, now you've got me worried. What are the symptoms? Should I be getting tested? I don't have a rash or a sore. Should my partner get tested? So maybe just more broadly, like, when should people be getting, aside from when they're pregnant, right? If you're pregnant, everybody should get this. But I think Jess is just wondering,
Yeah, I think it's we need to, it's really important for all individuals, sexually active individuals, to follow screening recommendations. And it goes back to the providers, right? Providers should know when, where, and what site to test. But what my recommendation will be, if you have any signs or symptoms information, talk to your healthcare provider, mention that you want to be, you're sexually active or just to screen you. Not only, I would advise screen not only for syphilis, but for other sexually transmitted infections, because we see a lot of individuals who are diagnosed with syphilis, but co-infected with other sexually transmitted diseases as well. So I would say that annual screening, it's required. So, and with respect to the signs and symptoms, again, it might not be syphilis. It's not necessarily syphilis if individual has a rash or, lesion, but it's always helpful to have a screening and confirmation based on lab results.
Yeah, and Jess, I'll just echo, as someone who provides primary care, doctors are really, really used to talking about this. So lots of times patients, feel kind of embarrassed about, talking about sexual partners or sexual history or concerns that they have, but you shouldn't feel embarrassed about that. It's really your doctor's job to be asking about it, but if they don't, you should be bringing it up. One of the things that makes syphilis screening a little bit different from like chlamydia or gonorrhea, which are a little more common, is that chlamydia and gonorrhea you can check for in urine. And so pretty commonly, people who are sexually active will have that urine testing, but really generally if you're adding on syphilis testing, it does need to be a blood test. So it's a little bit more of a conversation, but if you're having a new partner, if you're concerned, all of those are all excellent valid reasons to get the screening done. These sexually transmitted infections, they're all treatable, but if you don't know that you have it, you can't get treated, and then you can continue to spread it. And you mentioned this, but I just want to echo that partners are also really important in this.
Absolutely.
Katie is asking, saying 50% of untreated infections result in bad pregnancy outcomes. That's really scary. Does the state of Illinois require testing for syphilis?
Yes, state of Illinois required testing and during the pregnancy and in overall. So, and I will focus specifically about pregnancy. Testing should be done. It's called Prenatal Syphilis Act, and testing should be done during the first trimester of the pregnancy and again during the third trimester. CDC's recommendation is also adding that if female lives in community areas with a high prevalence of syphilis, or if female has any risk factors, as I briefly mentioned during our conversation, how we define risk factors, is highly recommended to receive the testing again at the time of the delivery as well. So 3 times during the pregnancy, it's must. However, for females who are sexually active and if they don't have any risk factors, so it's recommended to be screened at least once in a year.
All right, perfect. And can you just, someone actually has a question in here about mental health clinics, which I'll address in a second. But can you just talk briefly? There's folks who didn't know that the city operates STI clinics. Can you just tell folks a little bit about that?
Yeah, absolutely. City of Chicago operates the STD specialty clinic. We have 3 clinics, and they are strategically located in the different parts of the city. We have one clinic which is located in the Lakeview area. We have another clinic which is located in the South Austin area, and we have a third clinic which is located in the Roseland area. Our clinics are seeing patients on the walk-in patients, and it's pretty much safety net clinic, so there is no charge. It's a free of charge clinic who is doing the full set of the testing as well as the treatment, same day testing and same day of treatment. And as I mentioned that, we see different populations across the city, and so I think it's I wanted to mention that actually yesterday we released our very first report for STI specialty clinic. It's a brief report which provides information about what is done in CDPH STD specialty clinics with respect of how many tests we're doing, what type of tests, and this report was released yesterday.
All right, perfect. So you can find out more about that on our website, but we take appointments. We also do take walk-ins. You might have to wait if you don't have an appointment, but we are set up to make sure people can get served and can get the treatment. All right, so we're actually just about at time. There are a couple of questions here not related to STIs. So I will just take this one. John Asplin from Facebook is asking me, unrelated, what is my reaction to Brandon Johnson saying he would not want to keep you on? What about the reopening of mental health clinics run by city employees? So I will say that it has been a long campaign season, I think, for everybody here. My intent is absolutely to continue working in public health. This is what I do. This is my expertise. If I am not able to do it in Chicago, I will be doing it somewhere else. But my intent is to absolutely continue to do this work. I love it. I love my team, all of these areas. And so regardless of who is elected mayor, we will have that conversation. And to the point of the reopening of mental health clinics run by city employees, actually, 2 weeks ago on Facebook, I had Matt Richards on, who is our Deputy Commissioner for Behavioral Health, and we did a whole almost hour actually talking about this, talking about what is actually happening in the space of mental health and mental health clinics, what is happening in the space of building a network, trauma-informed centers of care, what are the ways in which the health department has been working to move resources outside of the walls of clinics, and really based on data, where are the gaps? So not everybody realizes that CDPH does operate still in the same way we operate 3 sexually transmitted infection clinics, and we operate immunization clinics, and we take care of everybody in the city who's diagnosed with tuberculosis. We operate 5 mental health clinics. And that is a piece of a much, 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 much larger system. We talked more last week, and I could go on for a long time about some of the funding structures that sort of go into this. But the most of the funding that comes to the Department of Public Health is from the CDC. It's by far our largest grantor. And at this point, about 90% of our funding comes from the federal government. All of that public health treatment, everything from CDC, cannot be used to treat individuals, period, because that is not actually the bread and butter work of public health. It's the work of preventing disease. It's the work of kind of bringing work outside of the clinics, home visiting, the policy systems, environments that promote health. But the direct provision of medical care is actually not even in the traditional work of public health. Where there are gaps, we help fill them. But most of our work is around sort of that systems. How do we make sure every single person in the city of Chicago, regardless of their income, regardless of their immigration status, how do we make sure they can get the care that they need without barriers? That's really the way we think about it as a department. It's as true for sexually transmitted infections as it is for mental health. And so, over these last few years, where there's been such an increased need for care for sexually transmitted infections, for mental health services, we've really doubled down on this. And so, I'm really proud, honestly, of the fact that not only have we increased the clinical services that the city operates for mental health, we now serve children, which we had never, ever in the past served children. We now have evening hours. We now have, much more ability to kind of fill gaps in those places. But we also are now making sure we have placed clinicians in almost more than 170 sites around the city. We are paying for therapists. We are paying for psychiatrists. We are paying for folks focused on child mental health to provide no barrier, high quality mental health care. And having a network of almost 200 places across the city that we can then, when we have somebody who has a mental health need, we can make sure they can get the care that they need. That's my primary goal, always at the health department, making sure people can get the care that they need without barriers. So, as I said a couple of weeks ago when Matt and I were talking, we're not against clinics. Of course we're not. And we certainly, where we see needs and gaps, we work to fill those. Right now we've got CDPH folks, for example, who are, we stood up CARE to embed professionals into the 911 response. That's work that nobody was doing, but also nobody else can do that. That's city work. We've worked to make sure that we are doing much more for people with higher mental health needs. Honestly, the biggest gaps are not in the outpatient, make an appointment for 10 a.m. on a Tuesday. The bigger gaps are often in the people who are also experiencing homelessness, who have co-occurring disorders with mental health and substance use, who are experiencing a lot of other issues and may have a higher need of care than sort of an outpatient clinic can develop. So that's why we're developing things like stabilization housing. So we're not against clinics at all. And we have grown our clinicians and our number of mental health staff at the health department. We've, I think doubled it, or, just over these last 4 years. But it has to do with making sure that where we are using City of Chicago taxpayer dollars, they are being used to make sure that the people who most need care can get that care barrier free. I use the analogy of immunization sometimes. The health department operates some immunization. We operate some immunization clinics. We operate, mobile services. There's been much more of that, of course, during COVID. But do you think CDPH employees put 5 million plus vaccines into the arms of everybody in Chicago during COVID? No, it's not possible. What we do is coordinate the hundreds and hundreds and hundreds of providers who provide those vaccinations. We work to see where are there gaps, where do we fill in, where can we do things outside of the walls of clinics. We track our success based on how vaccinated is Chicago. I don't make a difference between did that Chicagoan get their vaccine from a CDPH nurse versus a nurse in a federally qualified health center versus a school nurse. But I do want to make sure that where we're seeing community areas or demographic areas fall behind, that's where the health department puts its resources. And so that's really how public health thinks about care. It's about removing barriers, but that healthcare piece is actually a pretty small part of the work that we do. So that's what I have to think. That's what I have to say about that. And it's always interesting. My commitment is always to public health. That is what I do. That is what I care about. And I sort of let the politics happen over here. Certainly continue to look forward to working with the next administration, regardless of what that decision may be. This is the work that I will always do. So. Thank you for that. We are not on next week. I am actually going to be in Seattle. There's a big conference related to healthcare associated infections, and all of the people who we work with in hospital settings to prevent the emergence of like scary antibiotic resistant bacteria and other problems. So it's a really interesting scientific conference, and I'm looking forward to being there for a couple of days. So we won't be on next week. Amanda DW on Facebook, I see you. Thank you, Dr. Arwady. And I appreciate everybody who has sent lots of positive comments and notes to me, frankly. It's interesting. I'm glad that public health is getting as much attention as it is in these, in this particular election. It's a different time for public health. And I have appreciated the many notes that I have gotten from many of you. Supporting me, but really supporting the work of the department. What I care about is that public health gets the resources that it needs, and that we do the work of making sure everybody in this city is able to live their healthiest life. That's my goal at the end of the day, and it always will be. So we will see you then in 2 weeks. Again, this is Dr. Irina Tabidze, who joined us today. Long-term, really experienced leader at CDPH, working on sexually transmitted infections. And one more example of, folks who are a little more behind the scenes, but who help us keep this city safe and help keep individuals protected every day. So thank you again to you and to your whole team. We will see you back week after next. Thanks so much.